2-minute warning. Just waiting 2 minutes for a couple of committee members, and then we'll start. Thank you, guys. All right, I think we'll get started. Dr. Walter, I want to introduce the influenza session.
Good morning. It's my privilege this morning to be able to introduce the influenza session for today, February 21st. So these are the members of the influenza working group, quite a long list. I will note here that we have the addition of two of our new ACIP members who are now added to the influenza working group, both Robert Atmar and Hank Bernstein. Hank is actually a longtime member of the flu working group as well. And also not mentioned here is our work group lead who does a lot of the heavy lifting for influenza, Lisa Grosskopf. I'd like to acknowledge her. So just recapping our influenza session back from October 2000, the last meeting, 2017. At that meeting, we had an update on influenza surveillance really prior to the start of the current influenza season. We had updates on vaccine coverage, and then at that meeting, we also had a presentation on live attenuated influenza vaccine, really talking about the ferret model for protection for the Slovenia strain. We also at that meeting had a discussion from the vaccine safety data link study looking at spontaneous abortions following inactivated flu vaccine. Since the October 2017 meeting, we've had meetings or calls twice a month. We've continued discussion regarding live attenuated influenza vaccine. We've really looked at several different issues in the working group. We've reviewed data that you'll hear today from the combined U.S. individual patient-level data analysis of live influenza vaccine effectiveness. We have also reviewed data from this systematic review of LAIV effectiveness, which Dr. Grosskopf will be presenting. And then we had an update from MedImmune on U.S. pediatric shedding and their immunogenicity study, and you'll be hearing data from that today. So for presentations today, we have a rather lengthy flu agenda. So the first presentation will be given by Dr. Leonard Friedland from GSK, looking at the efficacy of Fluarix quadrivalent in children 6 through 35 months of age. As many of you may know, that vaccine had an extended age indication approval down to 6 months of age. I believe that indication was received in January of this year. We'll have a surveillance update from Lynette Bramer for our very active influenza season this year. That will be followed by a talk from Brendan Flannery from CDC on vaccine effectiveness for this year. Then we'll have a presentation from MedImmune looking at the results of a randomized trial of the new LAIV H1N1 strain in the quadrivalent vaccine or in the LAIV vaccine in U.S. children. That'll be, again, presented by Rayburn Mallory of MedImmune. That'll be followed by a review of LAIV effectiveness for 2 through 17 years old by Dr. Lisa Groskopf. And then we'll have considerations and proposed recommendations today for a vote by Dr. Lisa Groskopf. Dr. Friedland?
Well, good morning, everybody. Thank you very much. My name is Dr. Leonard Friedland from the Medical Affairs team at GSK Vaccines. And I'd like to thank the CDC and the ACIP for the opportunity today to present results of a randomized controlled trial that makes contributions to the evidence base for influenza vaccination of young children. On behalf of my colleagues, I am pleased to present the results of study DQIV-004, a large, randomized controlled trial of 12,000 children, providing high-quality data on influenza vaccination prevention in young children 6 to 35 months of age. We also want to acknowledge the families who elected to enroll their children in this very large study and their contributions to the generation of clinically relevant information on the use of Fluarix quadrivalent in young children. Now, GSK is proud to have 2 licensed seasonal influenza vaccines in the United States, Fluarix quadrivalent, which is manufactured in Dresden, Germany, thus the DQIV on the slide, and also Flulival quadrivalent, which is manufactured in Quebec, Canada, thus the QQIV. The dose of both vaccines for people of all ages is 0.5 ml per dose. Both vaccines are now indicated for people 6 months of age and older, with, as Dr. Walter mentioned, Fluarix quadrivalent receiving FDA indication for license as young as 6 months of age last month in January. Both vaccines are also administered intramuscular, as are all of the currently recommended influenza vaccines for children, where pediatric vaccination rates have remained at about 60% over the last 3 seasons. GSK purposely chose to develop both vaccines with a 0.5 ml dose for all people 6 months of age and older because the 0.5 ml dose potentially simplifies influenza vaccination by allowing the same vaccine dose to be used for all eligible individuals. Now, I'm going to focus my presentation this morning on the pivotal registration study that supported the recent FDA approval of Fluarix quadrivalent for children beginning at 6 to 35 months of age. And that study is referred to as DQIV-004. This trial was conducted in 13 temperate and subtropical countries between October 2011 and December 2014. In total, 12,018 healthy children were recruited in 5 independent cohorts, each in a different influenza season. Study DQIV-004 was a phase 3 observer-blind, randomized, controlled, non-influenza vaccine comparator study. As shown on the schematic, children were randomized 1-to-1 to receive Fluarix quadrivalent or the non-influenza comparative vaccines, which I will describe in just a moment. Stratification for enrollment was such that 10% of all enrolled were between the ages of 6 and 11 months, 35% of all enrolled were between 12 and 23 months of age, and 55% of those enrolled were between 24 and 35 months of age. Children were to receive 1 or 2 doses of vaccine. 2 doses of vaccine would be given for children who were considered to be influenza unprimed, meaning they had not previously received 2 doses of influenza vaccine. In reality, 98% of the 12,000 children enrolled in the study were influenza unprimed. There was also an immunogenicity subset taken from each of the 5 independent cohorts. And of course, there was influenza surveillance in this randomized controlled trial. The surveillance period encompassed the peak of influenza season in each country, which was based on available epidemiological data from the different participating countries or regions. These data were obtained from influenza surveillance activities that were conducted by public health bodies. And there was also safety follow-up through the entire course of the study, which lasted for each individual patient typically 6 to 8 months. These are the study demographics of the 12,018 children who enrolled. The mean age of those enrolled was 22 months. Approximately 49% were female. And the geographic ancestry is illustrated on the bottom of the slide, representing the countries that were enrolled. Overall, 24% of those enrolled were white, 45% were Asian, and 28% were other, which represented mostly mixed race and Hispanic. I mentioned this was a controlled trial where the control patients received a non-influenza control vaccine. These were the control vaccines. For subjects less than 12 months of age, the control vaccine was PCV13. For subjects greater than 12 months of age who were unprimed, which represented virtually everybody in the study, the first dose of control vaccine was hepatitis A vaccine, and the second dose of vaccine was varicella vaccine. The study used the following definitions of severity of influenza disease. Any severity of influenza was defined as laboratory-confirmed influenza with temperature greater than 38 degrees Celsius in any of the following: cough, runny nose, nasal congestion, or difficulty breathing. The study also used a definition of moderate to severe influenza. Our intention in evaluating moderate to severe influenza was to dichotomize cases into categories of mild illness versus illnesses that are associated with the most clinically aspects of influenza. Mild to moderate severe influenza was defined as laboratory-confirmed influenza with any of the following: temperature greater than 39, the presence of acute otitis media, lower respiratory tract illness, serious extrapulmonary complications, hospitalizations in the ICU, or supplemental oxygen. The study had 2 primary objectives. They're listed on the left-hand side of the slide. They were prevention of PCR-confirmed moderate to severe influenza due to any influenza strain. And the other primary objective was prevention of PCR-confirmed influenza of any severity due to any influenza strain. The study also had 7 secondary objectives, which are listed on the right-hand side of the slide. I'll give you a moment to take a look at them rather than read each of them. Now, in this slide, I describe the study procedures to detect and confirm influenza cases. There was active and passive surveillance that started 14 days after the last vaccination and lasted until the end of the influenza period to detect episodes of influenza-like illness, episodes of acute otitis media, and episodes of lower respiratory infection. Nasal swabs were then collected from subjects who had ILI, AOM, or lower respiratory infection for confirmation by PCR for influenza A or B. PCR confirmed samples were then further evaluated by PCR subtyping or DNA sequencing to identify the influenza A subtype or the B lineage. Then there was viral confirmation for influenza A or B. Culture-confirmed samples were then further characterized for antigenic matched to the vaccinating strains. And now on to the efficacy results. The study met its two confirmatory primary objectives by demonstrating vaccine efficacy against moderate to severe PCR-confirmed influenza at 63.2% and demonstrating efficacy against any severity of PCR-confirmed influenza of 49.8%. Here are the results of the 7 secondary objectives. Efficacy against PCR-confirmed influenza that was associated with lower respiratory illness was 54%. Efficacy against culture-confirmed influenza due to matching strains was 77.6% for moderate to severe and 60.1% for influenza of any severity. Efficacy against culture-confirmed influenza due to any strain was 63.8% for moderate to severe influenza and 51.2% for influenza of any severity. And efficacy against PCR-confirmed influenza that was associated with acute otitis media was 56.6%. The study enrolled healthy individuals. As a result, there were very few cases of severe disease that met our criteria. In fact, there were only 5 children who had severe complications of influenza, thus limiting our ability to be able to conclude on efficacy against severe influenza. On this slide, we illustrate the attack rates in the study and vaccine efficacy by strain. A few things to point out before I go through the vaccine efficacy by strain. The first is that attack rates were highest for H3N2 and for B Yamagata over the course of the study. And if we look at the proportion of antigenic matching strains, we note that most H3N2 and B Victoria isolates were vaccine mismatched. Now looking at vaccine efficacy per strain against PCR-confirmed protection against moderate to severe influenza, protection against H1N1 was 72.1%. Protection against H3N2 was 52.7%. Protection against B Victoria, 80.1%. And protection against B Yamagata, 70.1%. Now, a substantial proportion of healthcare utilization is associated with childhood influenza. Compared with controlled vaccine, Fluarix quadrivalent reduced general practitioner visits, emergency department visits, and antibiotic use that was associated with influenza illness by 47%, 79%, and 50% respectively. I'm going to move on now to the immunogenicity objectives in the study. Those objectives are listed here on the slide, and as previously mentioned, there was an immunogenicity cohort from each of the 5 independent cohorts throughout the study. And when I show the immunogenicity results in just a moment, I want to highlight again that 98% of the 12,000 children enrolled in the study were considered influenza unprimed. The immunogenicity results are shown on the next 2 slides. On the left on this slide, I show the geometric mean antibody titers pre- and post-vaccination, and on the right are the seroprotection rates for each strain. In orange are subjects who received Fluarix quadrivalent. In gray are the non-influenza controls. And what we see here is that Fluarix quadrivalent was highly immunogenic against all vaccine strains, showing high GMTs and seroprotection rates compared to controls. On this slide, we show the increase in mean geometric antibody titers pre- and post-vaccination and seroconversion rates for each of the 4 vaccine strains, again showing that Fluarix quadrivalent vaccination in this case resulted in anywhere from 9 to 17-fold increases in antibody titers after vaccination and also high seroconversion rates to each strain. Now I'm going to move on to the safety objectives. They're listed here on the slide. I'll give you a moment to look them over. And here's a schematic of the way that we collected safety information in the study. So this slide shows the incidence of solicited local symptoms, injection site pain, redness, and swelling that was reported by subjects in the study 7 days after each vaccination for dose 1 and for dose 2. Subjects who received influenza vaccine, Flurix quadrivalent, are in orange. The non-influenza control vaccines are in gray, showing that rates of solicited local symptoms after each dose were similar between those who received the flu vaccine and those who received the non-influenza control vaccines. And in general, reporting rates were lower after dose 2 compared to dose 1. Similarly, here are the incidents of solicited systemic symptoms that were reported 7 days after each vaccination, again showing that reporting rates were similar in those who received Flurix quadrivalent compared to those who received the non-influenza control vaccines, and in general, reporting rates were lower after dose 2 than after dose 1. My last safety slide is right here, where we review the incidence of unsolicited symptoms, medically attended events, serious adverse events, and potential immune-mediated diseases in subjects who received Flurix quadrivalent and those who were in the control arm. As you can see, the rates of all of these symptoms were similar in those who received Flurix quadrivalent compared to those who received control. I do want to point out the numerical imbalance in potential immune-mediated diseases throughout the course of the entire study, which spanned 6 to 8 months for subjects. There were 5 reports in those who received Flurix quadrivalent compared to no reports in those who received control vaccines. We conducted a detailed review of each of these individual cases. There were some confounding factors, and in all cases, there was insufficient evidence of a causal association. So what is the relevance of this study? This was a large, randomized, controlled trial of over 12,000 young children that provided high-quality data on vaccine prevention of influenza illness in young children. The study collected data from various different regions over multiple seasons, thus providing a typical vaccine efficacy value. And there was a large data set with exploratory analysis by subtype and lineage and also by age group. And we employed the application of a classification method to characterize the clinical severity of influenza cases. And we were also able to assess the impact of influenza vaccination on outcomes that were related to healthcare utilization. And so in conclusion, Flurix quadrivalent at the 0.5 ml dose in young children 6 to 35 months of age demonstrated efficacy of 63.2% against PCR-confirmed moderate to severe influenza and efficacy of 49.8% against PCR-confirmed influenza of any severity, and this was in the setting of mismatch to circulating strains. Flurix quadrivalent reduced healthcare utilization, antibiotic use, general practitioner visits, and emergency department visits that were related to confirmed influenza illness were lower in those who received Flurix quadrivalent compared to the non-influenza control vaccines. Flurix quadrivalent was immunogenic against all 4 vaccine strains, and the safety and reactogenicity profile was similar to vaccines that were used in the same age group, and there was no safety signal that was observed. The 0.5 ml dose, which is indicated for all eligible individuals 6 months of age and older, potentially simplifies influenza vaccination. And importantly, these study results support universal vaccination of all children from 6 months of age and older to prevent influenza. Thank you very much.
Thank you, Dr. Friedland. Are there questions for Dr. Friedland? Yes, Ms. Pellegrini.
Thank you for this presentation. I'd like to congratulate you on including a very diverse cohort of children from across the world and from presumably many levels of socioeconomic status and so on. Did you break down the results based on either geography, race, ethnicity, or some of those other factors?
Yes, thank you very much, and we were very proud to have conducted such a large study generating high-quality data. And the large data set allowed us to look at many various factors, including efficacy by age, by gender, by country, et cetera. And in general, the results all pointed in the same direction, that the vaccine was highly effective against moderate to severe influenza and influenza of any severity, including by strain as well.
Dr. Szilagyi?
Thank you very much. Actually, I had a similar question about demographics, but a second question about the 5 cases of potential immune disease that you investigated. Could you just give a little bit more information? Did they have pre-existing conditions? What was the time since vaccination, et cetera?
Oh, absolutely. So in a large study, many different reports will happen. All of the cases that were reported, which I'll review in just a moment, occurred at background rates that we would expect in the general population. So in more detail, what were the 5 cases? The first case was a patient who presented 21 days after the second dose of vaccination with a high fever of 39.4, had a petechial rash, had an evaluation which ruled out serious bacterial invasive disease, and was noted to have thrombocytopenia. The diagnosis was ITP, which resolved on its own 7 days later. There was a case which occurred 33 days after the first dose of a patient who then presented with a URI, fever, ear pain, and developed facial asymmetry. So the diagnosis there was facial paralysis. This resolved on its own within 2 months. There was a case of a child 13 days after dose 2 who developed nephrotic syndrome, who had a normal renal biopsy. There was another case of 8 days after dose 1 of a patient who developed facial paralysis. Of note, this patient had received varicella vaccine 23 days earlier. And the 5th case was a child who 206 days after the second dose of vaccination was diagnosed with celiac disease.
Dr. Fry?
Thank you. My question was just asked.
Okay. Other questions for Dr. Friedland? Okay. Thank you very much.
Thank you.
So Ms. Bramer? Yes, there she is.
Good morning. I'll present a brief update on influenza surveillance for this season. The slides that I'm going to show are for this season through the week ending February 10th, and I'll begin with our influenza virologic surveillance. If you look at the graph on the left, that is influenza positives reported to us by clinical labs across the country. And we use this data primarily to look at the percent of specimens that are testing positive for influenza to track the course of the season. The overall percent positivity is shown as the black line. And the thing to note here is that for the last 5 weeks, that has remained relatively flat. Since the week ending January 13th, the percent of specimens testing positive for influenza has ranged between 26.1 and 26.7% positive, so staying fairly consistent for quite a while. If you look, though, at the percent positivity specifically for influenza A, which is the yellow dotted line, you can see it looks like percent positivity for influenza A may have peaked during the week ending January 13th and has gone from 21.8% positive down to 16.9% positive for the week ending February 10th. But at the same time, percent positivity for influenza A has been going down, percent positivity for influenza B has been going up, giving us the overall relatively level levels. And that has increased to 9.6% positive for the most recent week. If you look over on the right-hand side, that is data from our public health laboratories that give us a more detailed view of what viruses are circulating. For the season overall this year, we've seen 82% of our viruses were influenza A viruses, although in recent weeks that has declined to 66% for the most recent week. Among the influenza A viruses that are subtyped for the season overall, 89% of those have been H3N2 viruses. Among the influenza B viruses, 91% of the influenza B viruses that have been lineage tested have belonged to the B Yamagata lineage. This next slide shows the genetic groups that each of the viruses belong to. And on the left-hand side is the overall number of viruses reported through surveillance to sort of put the data on the right into context. First of all, if you look at the influenza A, H3N2 viruses, the majority of viruses, 84%, fall into the 3C2A genetic group, which is the genetic group that the vaccine strain belongs to. 15% belong to the subgroup 3C2A1, and a small proportion, 1%, belong to 3C3A, which is the older group that the Switzerland vaccine strain came from. Looking at the H1N1 viruses, all of the viruses belong to the 6B1 genetic group, which is the same genetic group that the vaccine belongs to. For the B Victoria viruses, all of the viruses belong to the V1A genetic group, but 52% belong to a subgroup that has a 2 amino acid deletion in the hemagglutinin, and we're referring to those as V1A2del or double deletion variants. And finally, for the B Yamagata viruses, all of the viruses belong to the Y3 genetic group. Moving to antigenic characterization of these viruses, for the H1N1 viruses, all 205 viruses antigenically characterized using ferret post-infection antisera are Michigan 45-like, which is the H1N1 component of this year's vaccine. For the H3N2 viruses, 98% of them are well inhibited by ferret antisera raised against A Michigan 15-2014, which is a cell-propagated Hong Kong 4801-like reference viruses representing the H3N2 component of this year's vaccine. And basically what this means is that we are not seeing noticeable antigenic drift in these viruses. However, a lower proportion, 64.4% of the viruses tested were well inhibited by ferret antisera raised against the egg-propagated Hong Kong 4801 reference virus. For the influenza B viruses, 45% of the B Victoria lineage viruses that we've tested react poorly with ferret antisera raised against cell-propagated B Brisbane 60 2008 reference virus. And this virus is in both the quadrivalent and trivalent vaccine this year. And all of these low-reacting viruses had the V1A double deletion in the hemagglutinin. Among the B Yamagata viruses, all viruses were antigenically similar to B Phuket 3073-2013, which is included in the quadrivalent vaccine this year. Looking at illness caused by these viruses, on the left-hand side is the percent of outpatient visits for influenza-like illness, and in the most recent week, 7.5% of visits were for influenza-like illness. And this is higher than we've seen since the 2009 pandemic, when the peak was 6.1% for seasonal influenza, and more similar to what we saw during the 2009 pandemic, when it peaked at 7.7%. Looking at the right-hand map, this is state-level influenza-like illness activity levels. During the most recent week, we had 43 states, New York City, the District of Columbia, and Puerto Rico reporting high influenza-like illness activity, or 46 of the possible 53 jurisdictions at high. We've had more than half of all jurisdictions at high since the week ending December 30th. Previously, the largest number of jurisdictions reporting high in a single week was 31. So we've been considerably higher than we've seen in the past, and it's remained high for quite a while now. To look at the geographic spread of influenza, on the left is the ILI, on the left is the ILI map, and you can see even for those states that aren't showing high levels of ILI activity, they are having geographically widespread influenza. For the first 3 weeks of 2018, we had 49 states each week reporting widespread influenza activity. And for the most recent 3 weeks, we've had 48 states reporting widespread activity. So a very long period of time with very sustained widespread activity. The next slide looks at influenza-associated hospitalizations. On the left is the rates for this season. Overall, so far, our cumulative rate of influenza-associated hospitalizations per 100,000 persons is 67.9. That rate has been highest for people 65 and older at 294.9, followed by the 50 to 64-year-olds at 72.8 per 100,000. On the right, this compares the overall rate we've seen this year with all the seasons for which I have data for since through the pandemic. And you can see not only is the overall rate higher than any other season for the same week, it's higher than the end of season rate that we've seen for any season previously. The same is true for the 50 to 64-year-old age group, and the 65 and older age group is higher than the same week in time and is approaching, but not quite yet, the end of season rate for the 14-15 season. Moving on to influenza-associated mortality. On the left is the percentage of death certificates filed with the National Center for Health Statistics that have pneumonia or influenza listed somewhere on the death certificate. It looks like this percentage may have peaked during the week ending January 20th at 10.4%, which is considerably above the epidemic threshold for that week of 7.3%. But it is still lower than the peak percentage we saw in 14-15, which was 10.8%, and 12-13, which unfortunately is not on this slide, but that was 11.1%. So we are still below those seasons. On the right-hand side, you can see the number of influenza-associated pediatric deaths that have been reported so far this year. Right now, we've had 84 influenza-associated pediatric deaths reported to us. And the interesting thing about these deaths is that the distribution of viruses among these deaths is a little bit different than what we're seeing in surveillance data overall. So far, we've had 19 of those deaths due to H1N1 viruses, 19 to H3N2 viruses, an additional 23 due to influenza A viruses that were not subtyped, and another 23 were due to influenza B virus infection. Moving to vaccine virus selection for the 18-19 season, the WHO consultation on the composition of influenza vaccine viruses for use in the 18-19 Northern Hemisphere influenza season is currently going on. The meeting is being held February 19th through the 21st, and the announcement of their decision will be tomorrow. Next week, on March 1st, the Food and Drug Administration's Vaccines and Related Biological Products Committee meeting will be held to determine the U.S.-specific strains. So to summarize, influenza H3N2 viruses have predominated during this season, and may be going down, but influenza B activity is currently increasing. I feel compelled to say that influenza activity may have not peaked yet. I certainly hope it has, but it's been going on much longer than I had anticipated. This is the highest ILI activity we've seen since the 2009 pandemic. And while final severity can't be determined until the end of the season, it looks like, particularly for adults, hospitalization rates and mortality rates could be similar to or even exceed what we saw during the severe 14-15 season. The majority of circulating strains, though, are similar to those contained in the 17-18 vaccine. The B Victoria lineage viruses are the only viruses that we are seeing right now clearly showing antigenic drift, but these represent less than 1% of the circulating viruses right now. And vaccine virus recommendations for next season are being made this week and next. So we hope to have that information shortly. And that is all I have, but I'm happy to take any questions.
Thank you. I think we'll go ahead and have Dr. Flannery's talk first and then take questions on both, if that's okay.
Great. This will be a brief presentation on the 17-18 interim vaccine effectiveness estimates from the Flu VE network. The sites for the the vaccine effectiveness network are shown here with the principal investigators at the 5 sites in the U.S. Just as a reminder of the Flu VE network methods, these are outpatients age 6 months and older with acute respiratory illness and defined essentially as cough of less than 7 days duration, who are enrolled at the 5 sites. These enrollment data include November 2nd through February 3rd enrollments. The analysis uses a test negative design that looks at the vaccination odds among the flu positives compared to the odds in the flu negatives. And vaccination status for the interim estimate is defined as receipt of at least 1 dose of any of this season's vaccines, according to either medical records at one of the sites and immunization registries, but it includes self-report at 4 of the sites with any of the other information. Vaccine effectiveness is calculated as shown here, and there are several variables that are included in adjusted estimates shown at the bottom. So there are 4,562 outpatients who are enrolled during this period of time at the 5 sites. About 38% tested positive for flu, and the distribution of the positive cases is shown at the bottom. The 62% that tested negative, again, are the comparison group for the percentage vaccinated. H3N2 was the predominant virus at all of the 5 sites. We did differently than the surveillance data that were just shown. We did have a larger proportion of H1N1 PDM09, about 12% of all the positives. B Yamagata was the dominant B virus. This graph just shows the enrollment by week. The flu positives are shown in the orange color, and the gray shows the flu negatives. The bar shows the percent positive by week. And through the week of February 3rd, this followed very closely the ILI activity at the sites with lower percent positivity at the end of December, and then increasing rapidly through the beginning of February to about 50% in the last few weeks of enrollment before these data were drawn. The organization of this table is the same as the next 2, and the way we present the interim estimates. The first 2 columns of data show the number vaccinated among the flu positive, and the percent vaccinated was 43% overall. The second 2 columns of data show the percent vaccination among the flu negatives, and it was about 53%. And then the last 2 columns show the unadjusted and then adjusted vaccine effectiveness. The first row of data shows the overall all-age adjusted vaccine effectiveness of 36%, with a confidence interval from 27 to 44%. The estimates were statistically significant in the 6-month to 8-year-olds at 59%, and among the 18 to 49-year-olds at 33%. None of the other age groups had statistically significant vaccine effectiveness estimates. For the H3N2 specific estimates, again, the first row shows the overall all-age vaccine effectiveness of the adjusted estimate of 25%. That was statistically significant, but the only age group that had statistically significant estimates was the 6-month to 8-year-old age groups, and all the other age groups, the estimates were low and not statistically significant. For the H1N1 PDM09, just of note that the vaccine reference virus was updated for this season. So this is the first season with the A Michigan virus included in the vaccines. The overall adjusted vaccine effectiveness estimate was 67%, which was higher than during the 15-16 season with the previous vaccine strain. And it was statistically significant in the children 6 months to 17-year-olds and the 18 to 64-year-olds. The estimate was slightly lower and non-significant in the 65 and olders for H1N1 PDM09. For influenza B, the predominant, most of the influenza vaccine in the U.S. Flu VE network for all ages is quadrivalent. So the question of the inclusion of the B Victoria in the trivalent vaccine is perhaps not as relevant, except for the 65 and olders. We do not break out vaccine effectiveness by vaccine type until the end of season estimates, so that we have medical records and immunization records to be able to look at vaccine type. The overall estimate for influenza B for all types of B was 42% and statistically significant, again, in the 6-month to 17-year-old age group and 18 to 64. It was slightly lower in the 65 and older and not statistically significant. So in summary, the interim estimates through enrollment through February 3rd indicate overall effectiveness of about 36%, slightly lower for H3N2 at 25%, but was statistically significant. And of note, it was about 51% and statistically significant for young children, but no other age groups had statistically significant vaccine effectiveness against H3N2 at this time point. The vaccine effectiveness was higher at this interim estimate for H1N1 at 67% and was slightly higher at 42% for the B, all influenza B viruses, which were mostly B Yamagata. The final VE estimates will be shared at the end of season, and we use the final estimates to calculate averted burden, including averted cases or doctor's visits, hospitalizations, and deaths. And just as a note, after the surveillance update with comparisons of previous severe influenza seasons like 14-15, even with low vaccine effectiveness, we've seen that vaccination averts thousands of hospitalizations each year. During 14-15, the estimate was about 47,000 influenza-associated hospitalizations prevented, with a range from 11,000 to 144,000. So we expect that the final season vaccine effectiveness will be helpful in looking at averted burden this season. And then finally, this interim estimate again highlights the challenges with H3N2 component of influenza vaccines. And we just wanted to highlight a couple of studies that are looking at H3N2 effectiveness this season. One of the ones of note is from our Department of Defense colleagues. They will be looking at vaccine effectiveness of quadrivalent egg-based vaccines versus cell culture quadrivalent vaccine, both in their active military influenza surveillance population as well as in military dependents. And these acronyms stand for the Armed Forces Health Surveillance Branch and the U.S. Air Force School of Aerospace Medicine. So just to highlight, that will be done before, we expect that in the next several months and to be brought to the working group and eventually to ACIP. The other study that we wanted to highlight is comparative effectiveness. This is by the FDA and the Centers for Medicare and Medicaid Services data. They will be looking at hospitalization and medically attended influenza rates by vaccine type, and that will again include both cell culture vaccines as well as higher immunogenicity vaccines, high dose and adjuvanted vaccines for the elderly. We also at CDC are looking at immune responses to vaccine for this season, as well as the effects of prior infection and or vaccination. Both repeated vaccination is, I think, something that's relevant this season because the H3N2 component is the same as the 16-17 vaccine, but also looking at birth cohorts to see if we can understand better why vaccine effectiveness appeared to be higher in the 6-month to 8-year-olds compared to other age groups. And we will also, towards the end of the season, be looking at vaccine response by vaccine type, as I mentioned, and as well as serologic studies of response to different vaccines and the effect of prior vaccination. And again, this season, the CDC has increased sequencing of the positive specimens from the flu vaccine vaccine effectiveness network using next generation sequencing to look at changes, ongoing changes in the H3N2 viruses. And with that, I'd just like to thank the many people who are listed here and included in the MMWR who contribute to the VE network data. Thank you very much.
Thank you. It's a great presentation, a little depressing, but really impressive work. Do we have questions for Ms. Bramer or Dr. Flannery? Yes, Dr. Bernstein.
I was interested in the pediatric deaths. I was impressed that of the influenza A cases, that half of them were H1N1, and I was wondering if you had a breakdown by age of those that died, and also overall what the percentage was of those that were vaccinated.
Yes, I have it. No, I don't have it with me. Among the children with H1N1, I believe more than half of those children that died were less than 8 years of age. They tended to be younger. And for vaccine, I don't think the vaccination rate among the children with H1 were really any different than normal, which is around 20 or 25%.
Dr. Romero?
Do you have any data on serious complications such as myocarditis, encephalitis that is seen in children?
I would have to look at that. We do collect that information, but I don't know it off the top of my head.
Dr. Riley?
Do you happen to have data on kids less than 1 and whether or not mothers were vaccinated?
Unfortunately, we don't collect the mother's vaccination status with this surveillance.
Dr. Sun?
On your slide, I believe it's the 4th slide where you mentioned that there's sort of the discrepancy between looking at androgenicity with the cell-based versus the egg-based viruses. And so even though this year is a matched for H3N2, that seems to be a confounder. So do you have any data realizing that the cell-based vaccines have been available since about 2012? Have you gone back and looked at other previous seasons to see whether this kind of discrepancy between cell-based and egg-based has a similar effect on perhaps the overall effectiveness?
I don't think I do. Dr. Katz is on the phone from Geneva in the vaccine strain meeting, and the phone lines, I believe, could be open if she has any comments on that.
Yeah, so we can open up the phone lines. We ask that anybody who's listening on the phone who is...
The conference is now in talk mode.
Because there may be a lot of background noise, but let's see if we can get her on the phone.
Yes, hi, this is Jackie Katz. Can you hear me?
We can hear you great.
Okay. So, I mean, this is a common event that we see with H3N2 viruses because of the changes that we see with egg adaptation and having more impact on the antigenic profile of viruses, we always compare our look for antigenic drift, comparing with cell-propagated reference viruses, because the test viruses are also cell-propagated, and so that's the best comparison. And there we don't see any evidence of antigenic drift, as Lynette Brammer has indicated with her data. However, we often see, routinely see, that the proportion of circulating viruses when tested for their similarity to the reference egg-grown viruses, it's typically never as good as it is compared with the cell-grown reference viruses. So that is a common thing that we see with H3N2 viruses going back over many past seasons. Over.
Great, thank you.
Dr. Whitley-Williams.
Did you mention the number of deaths overall that were flu-related?
Pediatric deaths?
No, total.
We don't have a total number for all age groups. That we will have an estimate at the end of the year.
And that data will also be available in terms of broken down by race and ethnicity, is that correct?
I don't think we have the ability to do that.
We have some of those data in the emerging infections program at the end of the season.
That's true.
And those would be available by race and age. Dr. Messonnier.
I think, Lynette, you implied this, but maybe folks, just to say it, that pediatric deaths are nationally notifiable, therefore we have that data. Overall deaths are not. And so the flu program uses the data that they have to make estimates, but it's not exactly fully what you'd want, and it isn't exactly equivalent to the pediatrics.
Yeah, thank you for that clarification.
Ms. Pellegrini.
Thank you. The presentation didn't include anything specifically about pregnant women, so can you just confirm that we are not seeing any signals of concern or issues of concern among pregnant women this year?
The data that I would have to use to tell that would be the hospitalization rates, and the hospitalization rates among pregnant women are not different than what we've seen in previous years.
Dr. Hunter.
Doesn't the flu and pneumonia data have race and ethnicity from the death certificates?
It does. I believe most of them, I believe they do have that on the death certificates. We get a subset of that data, and our subset, unfortunately, our data feed does not include that information, but we could go back to the National Centers for Health Statistics for that information, yes.
Dr. Zahn.
Yeah, so I guess one question, for 6 months to 8 years of age, they seem to do better. For other countries that have had issues with vaccine effectiveness and concerns with egg adaptation, have they noticed that difference at all as well?
There are some data from the European network and from Canada, but the numbers are a little bit too small to really separate out better effectiveness in the younger children from those preliminary estimates for this season. The trend is similar, and the overall estimates are similar to what we see here, but the numbers are smaller in those other networks.
Okay. I'm going to take one or two last questions. Dr. Quash?
Yes, sorry, coming back to the pediatric deaths, would you have any idea of the proportion of children who were considered previously healthy?
Oh my goodness, I did look at that yesterday. I think it is I think it's about half.
Dr. Szilagyi.
Yeah, question for Brian. I'm just so puzzled by the 9 to 17-year-old data, and I know you don't have prior vaccination history yet because it's an interim analysis, but is there something different about those 100 kids, or about that age group, including the cases, compared to prior years? Were there more from one of the sites? Is there something unusual? Because it's just very puzzling.
We're wondering about that ourselves. The first thing, I think I can perhaps go back here. The first point to make is just that there is really no difference, and this is the H3N2 slide, but there's no difference between the 9 to 17-year-old and any of the other age groups over 8 years, just because confidence intervals include all of those estimates. If estimates are very low, when vaccine efficacy is very low or effectiveness is very low, we expect some of the point estimates to be negative. So we're not so alarmed by the negative point estimate, but it is concerning that they're all low. But to answer the question about differences in sites, we did have a very intense activity early season in Texas. Our Texas site has the lowest vaccine coverage in this age group. The study design should take care of that, but it is interesting that we had a larger proportion of our vaccinated 9 to 17-year-olds in the cases this year, and a lower proportion of vaccinated controls or the flu negatives than we usually see. This percentage, 35% vaccination among our flu negatives, is a bit lower than what we typically have seen in previous seasons.
Thank you. I think we're going to move on to LAIV just in the interest of time. So Dr. Mallory.
Great, so thank you so much. I'm Rayburn Mallory. I'm going to be presenting today the results of a clinical study we conducted to evaluate the shedding and immunogenicity of a new H1N1 strain that was included in LAIV or FluMist for the first time this season. And we conducted the study to see if this new strain that we picked based on some improvements we'd made to the strain selection process for LAIV, to see if this new strain was more immunogenic and was shed by a higher proportion of subjects than a previous strain that had reduced effectiveness. There are a lot of bullets on this slide, but they provide an overview of what I'm going to be talking about today. As you know, LAIV is not recommended for use in the US because of some reduced effectiveness that we saw for H1N1 strains in the 2013-14 and 15-16 seasons. And you'll hear later that the pooled estimate of effectiveness in those seasons was around 25%. We conducted an investigation to determine the reasons for this reduced effectiveness. We discovered that the H1N1 strains used in those seasons had reduced effectiveness and replicated less well compared to the older, highly efficacious LAIV strains. Based on these findings, we selected a new strain, the A. slovenia strain, that was included for the first time in the vaccine this season. And we conducted a clinical study to see if this new strain induced higher levels of antibody responses than an older strain, the A. bolivia strain, that had been used in 2015-2016 and had reduced effectiveness. What I'll present today are the results from the study that showed that this new strain induced statistically higher seroconversion rates compared to the older strain after both the first and second dose of the vaccine. In fact, the immune responses we saw for this new strain were similar to those seen for a previous, highly efficacious H1N1 strain that had been included in the vaccine previously. Findings from the clinical study we feel validate the improvements we made to our strain selection process. And this new strain selection process is being applied to all future LAIV strains. And the results will be submitted to both the FDA, EMA, and other regulatory authorities on an annual basis for review. This slide provides an overview of the study design. We enrolled 200 children, 2 to less than 4 years of age. And we picked this age group as we knew that shedding and immunogenicity would be highest in these young children. And this would give us the best opportunity to differentiate between the H1N1 strains in the study. Subjects were randomized to one of three arms. One arm received a trivalent version of the 2015-2016 vaccine with the A. bolivia strain that I've mentioned. Another arm received a quadrivalent version of this vaccine with the same A. bolivia strain, while the third arm received the 2017-2018 quadrivalent vaccine with the new A. slovenia strain. We included a trivalent arm in the study to see if interference might be occurring for the A. bolivia strain in the quadrivalent formulation, given the fact that this strain had replicative fitness issues in our lab investigation. All subjects in the study received 2 doses of vaccine 28 days apart, and immune responses were assessed at baseline, before the second dose, and then again 28 days later. Shedding evaluations were conducted on days 2, 3, 4, 5, and 7, and then again after the second dose on days 30, 32, and 34. Shedding was evaluated a little less frequently after the second dose, as we knew from older LAIV studies that shedding would be lower after this dose for all subjects. This slide provides an overview of the strains that were in each of the study arms. The trivalent 2015-2016 arm had the A. bolivia H1N1 strain, the A. Switzerland H3N2 strain, and a single B strain from the Yamagata lineage. While the quadrivalent 2015-2016 vaccine had these same 3 strains, as well as a second B strain, now from the Victoria lineage. Finally, the quadrivalent 2017-2018 arm had the new A. slovenia strain, a new H3N2 strain, the New Caledonia 2014 strain that was recommended by the WHO for use in this season, as well as the same 2 B strains as the other quadrivalent arm. The 2 quadrivalent arms, arms 2 and 3, represent the commercial vaccine that we manufactured and distributed for those seasons. Primary endpoint for the study was HAI antibody seroconversion rates after both the first and second dose of the vaccine. For immunogenicity, in addition to HAI responses, we also looked at neutralizing antibody responses, nasal IgA responses, and the proportion of children who had an antibody response in any one of these 3 vaccines, in one of these 3 assays. For shedding, we looked at the proportion of subjects shedding by day, the number of days of shedding, as well as viral titers. And safety assessment included solicited symptoms, adverse events, and serious adverse events. Moving on to the study results. The median age of subjects enrolled was 35 months. And there was a fairly even balance between male and female subjects. About 45% of the subjects enrolled had not been previously vaccinated for flu. We'd aimed to enroll about 50% of subjects without a previous vaccination history, as we knew that these subjects were more likely to be seronegative at baseline. And because we had data from older LAIV studies about how seroconversion rates in seronegative subjects might correlate with the efficacy for the vaccine. And I'll present some of these data later in the presentation. In terms of subject disposition, 195 out of the 200 subjects completed the study, and no subject withdrew due to an adverse event. Now I'm going to move on and present the shedding results. This slide shows the proportion of subjects shedding quantifiable vaccine virus by study day. The A. bolivia strains are in light and dark blue, while the new A. slovenia strain is in green. Looking at the data, you can see that the new A. slovenia strain was shed by a higher proportion of subjects on day 4 and day 5 of the study, consistent with the improved replicative fitness for this strain that we saw in our lab investigation. As expected, shedding after the second dose of the vaccine was lower for all strains. When we look at shedding data for seronegative subjects, this replicative advantage for the A. slovenia strain may be occurring as early as day 3. Moving now to the immunogenicity results for the study. And this slide has the primary endpoint data for the study: seroconversion rates for HAI antibodies after both the first and second dose of the vaccine. The study met its primary endpoint, as the A. slovenia strain showed statistically higher seroconversion rates after both the first and second dose of vaccine. Seroconversion rates in seronegative children were generally higher, with the A. slovenia strain again showing higher seroconversion rates than the A. bolivia strains, either the trivalent or quadrivalent formulations. This slide now shows the HAI antibody seroconversion rates after dose 1 that I showed on the previous slide. But I've now added the neutralizing antibody responses, the IgA responses, as well as the proportion of subjects who had an antibody response in any one of these 3 assays. Neutralizing antibody responses after dose 1 were similar to the HAI responses, with a somewhat higher proportion of children showing responses with the A. slovenia strain. IgA responses were somewhat lower for the A. slovenia strain, while when we look across the proportion of subjects who had a response in any one of these 3 assays, they were similar across the 3 study arms. Antibody responses after 2 doses of the vaccine, however, were more consistent, with the A. slovenia strain showing higher HAI responses, neutralizing responses, IgA responses, and a higher proportion of subjects showing an antibody response using any one of these 3 assays. Taken as a whole, these data indicate that the A. slovenia strain, which we picked for its enhanced replicative fitness, induced higher antibody responses than the previous A. bolivia strain in either trivalent or quadrivalent formulations of the vaccine. The data do suggest that there may be a potential for interference occurring for the A. bolivia strain when you look at the HAI and the neutralizing antibody responses. However, the shedding data that I showed previously and the IgA responses are less consistent with this conclusion. I think any potential interference that may be occurring for the A. bolivia strain is likely related to the fact that it had replicative fitness issues, as shown in our lab investigation. And I think it's important to note that the new A. slovenia strain induced higher antibody responses than the Bolivia strain, whether it was included in a quadrivalent or in a trivalent formulation. So we do have some data about how the HAI seroconversion rates in this study compare to seroconversion rates in older studies. And what you'll see on this slide is the HAI seroconversion rates for the A. bolivia strain and the A. slovenia strain compared to seroconversion rates in 2 to 3-year-old children from 2 older LAIV studies in which the H1N1 component of the vaccine had high levels of efficacy. Looking at the A. bolivia data, these results were lower than what we've seen previously. I think this is consistent with the reduced effectiveness for this strain that was seen in the 2015-2016 season. The A. slovenia strain, on the other hand, induced notably higher seroconversion rates. In fact, the seroconversion rates were similar to those seen in the older studies where the H1N1 component was highly effective. These data strongly suggest that the new A. slovenia strain will have improved effectiveness for circulating H1N1 strains. So to summarize the H1N1 data from the study, the A. slovenia strain was shed by a higher proportion of subjects from days 4 through day 7 of the study. And the study met its primary endpoint as the new A. slovenia strain induced statistically higher seroconversion rates after both the first and second dose of vaccine. And we saw similar results with the neutralizing antibodies and the IgA responses. In fact, the HAI seroconversion rates we saw for the A. slovenia strain were similar to those seen with a highly effective pre-pandemic H1N1 strain. So the study was conducted really to compare the new A. slovenia strain to the previous A. bolivia strain. But we do have data on the shedding and immunogenicity of the other strains in the study. Since recent seasons, including the current one, have been dominated by H3N2 strains, I'm going to show the H3N2 data from the study on the next slide. I do have additional data for the B strains in the backup, which I'm happy to discuss if we have time. So this slide is set up like the previous H1N1 slide. What I'm showing are seroconversion rates for the two H3N2 strains that are in the current study, the A. Switzerland and the A. New Caledonia strain. And I'm comparing those seroconversion rates to 3 older studies, each of which had a different H3N2 arm that was highly effective. As you can see, both the A. Switzerland and the A. New Caledonia strain in the current study induced high levels of immune response, and immune responses that were similar to 3 highly effective H3N2 strains. What you've heard today, though, is the effectiveness of IIV and LAIV has not been to the 75 to 95% level shown on this slide. And in fact, from the last season for which we have direct comparative data, 2016-2017, consolidated estimates for both LAIV and IIV were about 45% in children. And I think this somewhat reduced effectiveness that we're seeing for H3N2 strains is likely due to the issues that Dr. Katz mentioned regarding egg adaptation and the resulting antigenic mismatch for these vaccine viruses to the circulating strains, which has resulted in more moderate effectiveness. Before concluding, I wanted to touch on some of the key changes we've made to the way that we select strains for inclusion in our vaccine. The first change we made was to look at the replication of new strains in human nasal cells. Previous strains were assessed for fitness in MDCK cells and in eggs. However, for post-pandemic H1N1 strains, these results were not predictive of replication in human cells. The other change we made was to add the TCID50 assay to the way that we select and quantify strains. We'd previously used the FFA assay, and this assay measures the ability of viruses to infect cells and then to express protein on their surfaces. The TCID50 assay, on the other hand, measures the spread of vaccine virus from infected to uninfected cells. This requires the viruses to sustain multiple rounds of replication. For pre-pandemic strains that we include in the vaccine, these assays gave very similar results. However, we found for post-pandemic strains that the TCID50 assay gave values that were up to 3 logs, or 1,000-fold lower than the FFA results. What this means is that for the post-pandemic H1N1 strains that had reduced effectiveness, they may not have been able to sustain intranasal replication to the levels needed for optimal effectiveness. To fix this issue, all future strains will now only be selected if they have high levels of replication in human nasal cells and where the FFA and TCID50 assays give very similar results. These data will be submitted to the FDA, EMA, and other regulatory authorities as part of the data package that we submit annually to support ongoing licensure of the vaccine. So to summarize, we conducted an investigation to determine the reasons for the reduced effectiveness for the H1N1 strains in the vaccine seen in 2013-14 and 2015-16. And we discovered that these strains replicated less well compared to older strains. We picked a new H1N1 strain, the A. slovenia strain, with improved replicative fitness in the lab for inclusion in the vaccine for this current season. We then conducted a clinical study to compare the immunogenicity of this new strain to an older strain, the A. bolivia strain, that had reduced effectiveness. And the study showed that the new strain induced statistically higher seroconversion rates than the old strain. These results validate the changes and improvements we've made to our strain selection process. And this improved process is being applied to all future LAIV strains, with results being reviewed by the FDA and the EMA on an annual basis. We believe that FluMist is an important option for providers, patients, and parents in the US, as well as in other countries where it continues to be recommended for use. Thank you.
Thank you, Dr. Mallory. Questions? Yes, Dr. Rabb.
So in terms of, I have a question about your plans for testing future strains to be included. These include not just the H1, but H3 and B strains?
That's correct, all future strains.
And have you applied these criteria to past non-H1 strains like H3 or B, and to show that, in fact, you didn't identify any issues with replicative fitness?
We are applying those to past strains, and I think what the results show is that for the highly efficacious strains that we've seen in the past, the FFA and TCID50 assays are very close together. And as we move forward in the current season, we're applying these criteria.
Thank you.
Other questions? Dr. Hunter?
So as a clinician, I think I'm very impressed that you're doing everything you can to tell me what theoretically is going on with the vaccine and trying to reassure me, but I'm also wondering what future data are you going to have that relates to patients as far as does this really prevent infection? And so do you have a plan that you can talk about as far as studying that?
Sure. So as you may know, FluMist or Fluenz is the vaccine of choice in the UK for their national immunization program. So Public Health England generates effectiveness data on an annual basis. We don't have those results yet from this current season, but we expect to see them soon, and they will continue to generate that effectiveness data. So when H1N1 circulates again next, which we're not sure when that'll be, we will have effectiveness estimates for the vaccine from Public Health England and possibly from other countries like Finland and Canada, where the vaccine's being used and where vaccine effectiveness estimates are being generated.
Other questions, Dr. Bernstein?
So I'd like to echo what Dr. Hunter said. I think I applaud the efforts to address issues that you've identified since the previous versions underperformed in comparison with IIV, because I do think having an intranasal product is an important part of a vaccine program since it's a universal recommendation. My struggle is translating the shedding into vaccine effectiveness. How can we, with a small number of subjects, 200 total subjects in 3 different arms, LAIV3 and then 2 LAIV4, how does that translate into confidence that this is going to be effective in the clinical setting?
Right, so I think there are 2 questions there. One, the size of the study, and then how are the results generalizable? In terms of the size of the study, we picked 200 subjects because this would give us the ability statistically to see differences of around 20 to 25%. And we thought that differences in immunogenicity of around 20 to 25% between the strains would be clinically relevant. If the study was larger, we might be able to say that differences of 5 to 10% in immunogenicity were statistically different, but we didn't feel that these differences in immunogenicity would be clinically relevant. So the size was based on what we thought would be clinically relevant differences. In terms of how do the shedding and immunogenicity data kind of generalize the effectiveness, I think that's why we went back and compared the seroconversion results, and also in your backup slides, the GMTs, the actual geometric mean titers, to the older studies where the H1N1 component was highly effective. And I think it's very reassuring to see that the results we saw with the new A. slovenia strain were consistent with those previous results. And I think also seeing that the A. bolivia strains were somewhat lower, coinciding with the reduced effectiveness for that strain, also point to the kind of general applicability of these findings.
Thank you. Dr. Romero.
So 2 questions. First of all, you showed that that seroconversion rates to H3N2 weren't affected, but is there any data to suggest that there is no interference with the immune seroconversion rates to type B? And second of all, this may be a damned if you do and damned if you don't, but question, but in the original versions of your vaccine, shedding was a concern, and that is spreading to other individuals that might be at risk for immunocompromising conditions. Will your this new vaccine, will new recommendations be issued regarding shedding?
So I heard 2 questions. One was potential interference for B strains, and then the second one is, will there be new recommendations regarding shedding? So I'll answer the first one about interference with the B strains. The effectiveness for the B strains in the vaccine has been consistent in both the trivalent and quadrivalent versions of the vaccine. So when we look at effectiveness data, there's no evidence that interference is occurring for the B strains. In terms of shedding, in the original trivalent version of the vaccine, a large shedding study was done and showed a very, very low rate of transmission. I think there was only 1 case out of 200 children. The shedding rates that we saw in the current study are similar to those that we have seen in previous flu studies. So I don't expect that there will be any changes to the recommendations regarding who can receive the vaccine.
Dr. Szilagyi.
Thank you for your presentation. This may be a naive question, but I'm in my mind trying to translate. In the real world, in this age group, more than half of kids are previously vaccinated. So I saw the results for the seronegative, or the not, maybe the not previously vaccinated, but what were the findings for the for the numbers that were previously vaccinated?
So I think, if you look at backup slide number 24 in your deck, I think we have seroconversion rates for previously vaccinated. It may take me a while to get there. So here we have the HAI seroconversion rates by vaccination status. So I showed you on the left the all subjects. Next is the vaccinated subjects versus the vaccine-naive subjects. And as we expected, the seroconversion rates were a little bit lower in vaccinated subjects, but they weren't markedly different than the all subjects.
Ms. Pellegrini.
So if you could stay there, sorry, because I have a related question. I don't think it's the same question, but in the study design, can you help us understand why the decision was made to give all the participants 2 doses, given that if they were previously vaccinated, they would only be recommended for 1 dose?
Yeah, so the goal of the study was to see if we could differentiate between, there are 2 goals. One, to see if we could differentiate between the H1N1 strains in terms of their shedding and immunogenicity. But we also had the data from the older LAIV studies where we had seroconversion rates and efficacy data. And those were 2-dose data. So we made the decision to give subjects 2 doses so that we could compare the seroconversion rates to the older strains that we knew were highly efficacious.
Then to just follow up, does that mean that we could probably expect real-world usage results to be closer for those populations to the dose 1 results instead of the dose 2 results?
Maybe you can clarify that.
So if we recommend the vaccine, those children who are previously vaccinated are only going to get 1 dose of LAIV. So should we expect the results for them to be closer to that middle column for dose 1 than for dose 2?
I think we might expect to see seroconversion rates at about that level. I will say that the efficacy of a single dose of FluMist across the age group which it's indicated, 2 to 17 years of age, has been extensively reviewed by the FDA and EMA, and we know that the vaccine works in those subjects who receive a single dose.
Dr. Massonnier?
Maybe just to clarify for Cindy's question, one of the complicating things looking at this data, though, is that, in fact, while people have been previously vaccinated, they would not have been previously exposed to this H1N1 strain because it actually is a new strain to that population.
That's correct, and that's why we looked at results in seronegative subjects.
Unless they got IIV, and then they would have been, right?
Dr. O'Leary?
Yeah, thank you for that thorough presentation. If I remember right, one of the first hints that there was less effectiveness with LAIV versus IIV was in older children, 9 to 17. And so I'm just curious on the decision to just study this in the younger children.
So again, the reason we picked younger subjects for this study is because we knew that both shedding and immunogenicity would be higher in these younger subjects, and that this would give us the ability to differentiate between the strains. And we also had data from these younger subjects about how a highly efficacious H1N1 strain should perform. This is from the New Caledonia 99. So the study was really designed in younger kids to differentiate between the strains and to see how this new strain compared to a previous highly efficacious strain.
Dr. Brady?
Yeah, so again, I'm trying to understand how shedding and immunogenicity is going to pertain to eventual effectiveness, which is what we're looking for. And on slide 13, you provide high efficacy rates of 92 and 81% efficacy with the New Caledonia strain, yet it appears that the lower seroconversion rates had the higher efficacy. And again, it's just trying to take that leap of faith that we have actually identified the true correlate of protection based on the studies that you've done. Now, I mean, you've done a lot of really spectacular studies, but I guess the big concern that we would have is, have we truly identified what initially caused the lack of effectiveness, and by looking at immunogenicity, have we identified the correct correlate?
Right, so a couple of questions. One, I think, is around the 57, 59 on this slide. This is 92% efficacy, but the seroconversion rate in seronegative subjects was just 57%. I think that's because the majority of children in this study, study 1, were actually already immunized. So the all subjects and the seronegative subjects don't look that different. I think your broader question, though, was around, do shedding and immunogenicity for the live attenuated vaccine correlate with efficacy? And I think the best correlation we have is in these younger children that predicts the effectiveness of the vaccine.
Okay, one more question, Dr. Quash.
So I was just wondering if you were planning on repeating such a study in a second year, because in Canada, we've used less LAIV than you guys have used in the US, mainly because of cost containment. So we've used LAIV in some provinces only in subgroup of children needing more protection. So the question is, if you get repeated exposure to your LAIV, is that where you see decreased effectiveness, which might explain why we haven't seen it, beside the fact that we have less cases, less power to detect. But if you were to use this new H1N1 strain repeatedly, would you be seeing the same decreased effectiveness that you saw before? And I don't think none of your patients in that cohort has been exposed before, because your median age is 36 months. So if anything, they got intramuscular the year before.
I'd agree that this study was not designed to look at the effect of prior immunity on effectiveness. However, the effects of prior immunity in vaccine efficacy and effectiveness have been studied extensively in both the observational studies that the CDC and we have reported, as well as in the pre-licensure pivotal efficacy studies. And there's no evidence from any of these studies that prior immunity decreases either the effectiveness or the efficacy of the vaccine. The 2016-2017 season, we had a couple of studies from Finland and Japan where we had data on prior immunity, and there was no effect of prior immunity in 2016-2017 in those studies. For the previous season, 2015-2016 season, from a couple of studies, prior immunity actually seemed to increase the point estimates of effectiveness. So again, this study was not designed to look at prior immunity, the effects of prior immunity on effectiveness. It was really designed to differentiate between the strains and see how the new strain compared to the previous strain that worked well.
Thank you very much. Dr. Massonier?
That maybe we should let the next presentation go ahead, because I understand that she has some of that data specifically in there.
We are. That was the last question. So Dr. Groskopf?
Okay, there we go. Thank you very much. Good morning, everyone. This talk has 5 parts, some background to put some of the issues into context, and then a description of 2 CDC analyses, one a combined individual patient-level analysis of LAIV effectiveness data, including US data from 5 studies, then a systematic review and meta-analysis of published literature on LAIV effectiveness, which includes both US and non-US data, next workgroup considerations, and then finally a proposed recommendation. So background. I thought it might be useful, since it's been a couple of years, to just briefly summarize the history of the LAIV recommendations. LAIV was licensed as Flumist, a trivalent in 2003 for ages 5 through 49 years, and subsequently in 2007 for 2 through 49 years. It was recommended for healthy, non-pregnant persons within the indicated age range, without a preference for it over any other vaccine. In 2012, LAIV-4 was licensed. It replaced LAIV-3 for the 2013-14 season, and it was similarly recommended without a preferential recommendation for healthy non-pregnant persons. In 2014, ACIP approved a preferential recommendation for LAIV-4 for healthy 2 through 8-year-olds, the basis of which was pre-2009 pandemic data showing superiority of LAIV-3 to IIV. However, in February 2015, the preferential recommendation was removed following poor effectiveness of LAIV-4 against H1N1 PDM09 for 2 through 17-year-olds observed during the 13-14 season. There was no statistically significant effectiveness of LAIV-4 for these viruses, whereas LAIV was effective. In June 2015, we had a review of the 14-15 US flu VE data and also data from 2 other US studies. It was noted that there was no better performance of LAIV-4 than IIV against H3N2 viruses. We had actually poor VE for both LAIV-4 and IIV during that season, which was marked by a drifted H3N2 predominance. It was a little bit of a disconnect from what had been observed previously with LAIV-3, which had been observed to be superior to IIV for drifted H3.2 viruses in one very large pre-pandemic randomized controlled trial. For the 2015-16 season, LAIV-4 had a change in formulation. The H1N1 PDM09-like virus was changed to A. bolivia. The previous one that had been in place since pandemic was A. california. However, studies had revealed poor replicative fitness of that H1N1 virus, so bolivia was used to replace it. However, in June 2016, we observed poor effectiveness of LAIV-4 again against H1N1 PDM09 viruses, which again had predominated for the 2015-16 season. Consequently, LAIV-4 was not recommended for use in the United States for 16-17, and that was extended for the current season, 17-18. We thought it might be useful to look at a couple of slides very quickly from June